Okay. This is my topics. This is a sentence we wrote with my teacher, Skip Peerless, nearly 30 years ago. We continue to enjoy the perfect clip around the base of those deadly sacks. So this has been my life. And now working in China, perfect clip around the base of those deadly sacks. Is it over now? Like in the song, those were the days. So this is unruptured right middle cerebral artery aneurysm. I still think that these aneurysms should be operated on by clipping because they are superficial and simple for clipping, very complicated for endovascular surgery. This is the operation. Simple lateral supraorbital flap, one layer. And this is very fast. So in 10 minutes, I'm opening the dura, one burr-hole, 2 cuts. Then we have the flap here. I'm opening the dura, and then under high magnification, opening the sylvian fissure with needle as knife, and injecting water inside the sylvian fissure to distend it, and then opening the sylvian fissure distally, saving the veins, going to the aneurysm. Soon we will see the aneurysm wall. It was growing in the observation. Now we see that this white wall, this looks very thick, but there was a bleb that was growing, and that's why the patient was sent to surgery. Careful dissecting under high magnification, the aneurysm. And below the aneurysm is M1 coming from distal. So we dissect after clearing the aneurysm fundus. We clear the M1, go there. This is the bleb. There would put the aneurysm rupture in the thinnest part. And now we go to M1. See the perforators there. You should not put temporary clip around them, save them. For a short time, you put temporary clip here, going here, golden color clip, and then a J-formed clip is taking the broad base. And checking the situation, taking the temporary clip out carefully, and then checking the situation. We need another clip and 2 small additional clips to take the whole aneurysm. Coagulating, but this is here the wall is thick, so it is not so good for coagulation. And then putting a similar clip there, one more to take where the aneurysm is filling through the handle of the clip, and then here one more small clip. And then checking the patency of the M2s with Doppler, and then doing ICG also, and this is Doppler probe. And this is the post-operative CT angio. The patient flew home to Italy 4th day after operation. This was a sister of Guido Guglielmi, Maria Guglielmi. Why I'm showing that? Because it is important that the doctors select the best treatment for the patients, and you should recommend the most appropriate treatment for the patients. Patients are not doctors. Patients should not select the appropriate treatment. They should ask for the recommendations. So now I come to the point. How are we doing? This was the morning question of my teacher, Professor Skip Peerless in Miami, nearly 30 years ago, always. How are we doing? I could never answer that time. Terrible. Should I now answer? Terrible. How are we doing? Why microsurgery is going down? Why are we losing our skills? It is deep cap, fears, lack of skills, poor training, love of comfort, means less experience, fears coming, big threshold to operate on. So why microneurosurgery is going down? During my time in Helsinki, 95% of the aneurysms had open microsurgery. Now only 1/3 are clipped. So the times change. And in my present hospital, Henan Provincial People's Hospital, Zhengzhou, this is like a paradise for aneurysms, but more than 1,000 of them have endovascular treatment and 300 to 400 have clipping. So neurosurgery is not different from any sports, arts. Hard training is needed. So in good microsurgery, only training makes a master. You have eliminated tremor, analyze your experience, and microsurgery, the training is extremely long. So it is the regular rule is 10,000 hours training. You are at the world top. And this is my addition. If you have been 10,000 days in operation room, then you are at your best. So here is one more video I want to show. Now running. Yes, okay. So this is a giant basilar bifurcation aneurysm, 68 years old. Female, large ball-like aneurysm, right subtemporal approach, going to the tentorial edge. You see here the trochlear nerve, and then cutting the tentorium, fixing the tentorium to the middle fossa floor with clips, and then we go to the basilar artery, put temporary clip there, and also on both peak arms to have as slack aneurysm as possible, and then opening the aneurysm, because you cannot clip this aneurysm without opening it, so it is bleeding. There's also a small venous bleeding, and then first clip is ring clip going around the base, large base, and then many adjustments of the clips, because the first clip is closing the PCA. So I'm traveling with the clips backwards from the base of the aneurysm. The strong base, of course, in that kind of large aneurysm. So you have to leave some base not to occlude the bifurcation. And still bleeding, so means that the clip is not long enough. So finally, 2 strong straight clips to the big whole aneurysm, and bleeding stops. The ring clip is taken away and replaced by 2 strong straight clips. Now the temporary clips taken out, then ICG, checking with Doppler still, patency of, these are the postoperative images, and this is postoperative angio, 2 strong clips taking the giant basilar bifurcation aneurysm. The question is, of course, can I do it again? Can I repeat it safely? I have operated around 600 posterior circulation aneurysms. Can someone learn it? Someone younger, can it learn it to do well? Basilar bifurcation clipping needs long training. Could I do it again? Can someone repeat it safely? Can someone learn it? This is the question nowadays. So, huge pressure from surroundings nowadays. Media, colleagues, lawyers are speaking about endovascular surgery. This one, you can push the coils after training in 1 year in endovascular surgery. You cannot clip basilar bifurcation aneurysm with 1 year training. You need 10, 15 years training. This is the big difference, and of course, handicap for microsurgery. There's also a lot of money going around in this treatment. Many or most of us are seduced by the money. Money. Endovascular is one of the biggest business and heavy to compete. Quite frankly, if open microsurgery wants to survive, we have to be good and efficient, both. Only perfect follow-up tells the truth. This is extremely important and very seldom. So perfect follow-up is a must only in Finland and some other small countries. You have a good follow-up. I have been around the world and have seen the follow-up in so many countries. Worst or no follow-up in largest countries with the biggest economies, and also by those traveling around the world who are treating aneurysm, there's no follow-up. So time will tell. They will open their eyes, is my guess. I hear this many times in congresses, in my series. In metropoles, the follow-up is maybe 5 minutes, or we are waiting for the figures. You are waiting a long time, but you never get them. So without follow-up, you don't know what happens with 10, 15, 20 years follow-up. You will see recurrences, both in endovascular surgery, but also in open microsurgery, like you see right down. You see that the basilar superior cerebral artery aneurysm recurred 15 years later after surgery. So this is the series from Helsinki and Kuopio, extremely good follow-up. More than 22,000 aneurysms in 18,000 aneurysm patients followed up many years until their death in the databases. How to do better here in the treatment of aneurysms? It is never too late to train hard. Training, learning curve is all of your life. You should train your best young people. They should become better than you. This is very important. You should support them to become better than you. So nowadays there's extremely heavy pressure of the surroundings and society in favor of endovascular surgery. Those who are doing open microsurgery, they have to be mentally extremely strong. There are many different cultures around the world. One of the important things in China is that here is the habit to shave the female hair for craniotomy. This is, of course, in favor of endovascular surgery. This shaving of the female hair is one of the oldest and worst punishing violation of females. Also here in China, like in many other countries, there are superstitious thoughts that open the head is dangerous. And if you do very extensive approaches, they certainly look terrible and are complicated. You should do opening of the head simple, This is simple microsurgery. Lateral supraorbital flap from skin to skin. Middle cerebral artery aneurysm ligated in 25 minutes from skin to skin. So, and the flap should be large enough for your skills, for your instruments, for the lesions, because surgery is not sports. Patient is paying for that. Who have clipping nowadays in the world? Poor people in China, poor people, patients without insurance, and who have no treatment, like in Nepal. Poor people didn't have any money for even for a clip, so they went home. Lama left against medical advice. So nowadays, even neurosurgeons inform that the opening of the head is dangerous. This is not right, because you should, if you cannot open the head in safe way, then you should do something else than microneurosurgery. So there are many routes that go to Rome. You should take the shortest, cheapest, and best one, many times clipping, MC aneurysms, and many other aneurysms. Here is from our database, 22,000 aneurysms, some aneurysms that might be very suitable for microsurgery, large, giant aneurysms, middle cerebral aneurysms, more than 6,000 cases, patients with large intracerebral hematomas, hydrocephalus, and aged patients might have very tortuous vessels, difficult for endovascular surgery. So small MC aneurysms, they are superficial and simple for clipping, difficult for endovascular surgery. And anyhow, there are many difficult, or like Dr. Drake, my teacher, called impractical aneurysms, like here, giant thrombosed vertebral aneurysm, calcified aneurysm, and I will show more of them. This calcified MC aneurysm need bypass surgery. Giant tumor-like MC aneurysm was resected and clipped in a Jehovah's Witness, not accepting blood. Take a look, good flap, not a small flap for this case. And then you have patients with hematomas. This is young male, had 4 bleedings on Monday. Finally, in emergency room, both pupils dilated. I went to operation room, took the hematoma out and clipped the ACAM aneurysm, and the patient made recovery like miracle. Is not able to work as taxi driver, but is able to take care of his 3 children. So what is the future? At the moment, only 2/3 of the world population have, 1/3 have access to endovascular surgery. I think in future, we will have biological solutions to treat the aneurysms, and of course there is prevention. So China is a huge country, 5 times bigger than USA population, and here the aneurysms are common because of the male smoking and fatty food in both genders. So it is 7 to 10% of the population are carrying unruptured aneurysms. In USA, maybe 1 million people are running with aneurysms. So the price of pipeline here in China is very high as compared to clip. So I think like COVID-19 stopped traveling, maybe the high cost of endovascular treatment will reduce its use, and it can be seen already in bigger populations. Maybe the prices go down. This every year has been told that the prices go down, but it is very difficult to afford endovascular treatment to the huge number of patients with aneurysms. So, are you still clipping aneurysms? I think there is big need to continue clipping, because for me, this is the best and most durable aneurysm treatment in skilled hands. And skilled hands might be rare nowadays, but the perfect clip around the base of those deadly sacs remains extremely good treatment if it can be put into place. So for the good treatment, you need good team. You are not doing alone. Here is in our hospital, good scrub nurse, ping, and good anesthetic team, and this gives you good results. So about the annual surgery videos, all of them can be seen free in internet. You can search by Hernesniemi 1001, around 1,600 videos, and the Helsinki microneurosurgery book in many languages can be also found there. My student Behnam Jahromi is now finishing his PhD book on this monstrous aneurysms. He has huge collection of these atherosclerotic giant aneurysms, 519 cases, and the book will come next year out. We developed slow closing clip for treatment of these terrible aneurysms, which resist all kind of treatments. So I thank you for your attention, and kiitos seisei.
Thank you very much, Juha, for this comprehensive presentation covering part of your experience, and thanks for sharing your experience. There is no questions. Look like people, they are just listening to this marvelous experience. I have
there's just one question just while you were speaking, I think.
Yeah, let me first give my question and then we'll go for this one.
Perfect.
I want to ask you, Juha, we have here your friend and counterpart on the intervention, and Professor Jacques Moret from France. He joined us here on the webinar, and you have collaborated. Yeah, you have collaborated with him. I know that time from your time in in Scandinavia. In which situation you have referred cases for him to do interventional radiology? What are the cases you felt you don't want to touch it? I know you have vast experience in many, but I'm sure there are some cases you elected to seek his role in the management. So what are the cases?
When we were sitting in Helsinki in operation room, both of us were saying that we can treat 100% of the aneurysm. That was the situation. But of course, we had difficult cases. Jacques Moret came to help in AVMs and aneurysm to Helsinki. This was the way. Usually, it was more simple for him to come to Helsinki than for us to send the patient to Paris.
Can you give us, for the sake of the trainees, they understand what difficulty even the most experienced person in aneurysm surgery, that he is obliged sometimes to move some to intervention management? Which are the cases you have referred to him that you felt they are not going to be the best treatment by clipping?
During my time, all cases were done by open microsurgery, except I was traveling, then they had endovascular treatment.
So you have not referred to him any cases unless by default?
There are also, of course, there are also endovascular surgeons in Helsinki, and now they are very florid. They're doing a lot of cases, more than clipping. So this is, of course, the spread out and for many reasons. Okay. So I showed in one slide that during my time, 95% of the aneurysms were clipped, and then nowadays only 1/3.
1/3. All right. So we have one question. Go ahead, Sanjeeva.
I think this question has come from a Dr. Harshad Parekh, and it's a general question, I think for Professor Hernesniemi and Professor Katto, asking, in giant aneurysms such as giant basilar tips, when would you advocate bypass surgery? I know it's very case specific, but the question has come in quite a general manner. What are your thoughts? Professor Hernesniemi, Professor Kato?
I think the basilar bifurcation aneurysms are not good for bypass surgery. You have to clip them out and treat with the present endovascular means with the different stents and coiling. But one of the difficulties in basilar tip or other giant aneurysms that they are usually they are recurring and they are pressed inside the brainstem. So you might have pushing more and more coils, and then they grow inside the brainstem. So this is the difficulty. It is, of course, like I showed the case of clipping of basilar bifurcation, it is not easy. And I was questioning if I can do it again all the time, or if somebody can learn it. So it needs a long training and also good surrounding, supporting surrounding for that. So it means
Any
team
question? Oh, sorry. Any question from the panelist or comment?
I think Prof. Kato wanted to say something.
Yeah, Professor Kato.
The Juha showed us a very attractive, the giant vascular tip aneurysm, but I think that recently so many stents is coming up. I think so no more coil compaction, or I think those type is we should always think about the perforators, and also of course the bypass is the way we can survive with the perforator function. I think that is one of the way we can save the perforators. But I think many at the end of us advancement we should appreciate, I think. Thank you.
I didn't say anything. I said that if I can do it again, or someone can do it again during these times. Times have changed. The pressure for endovascular surgery is extremely hard. Even sometimes they recur, and it is not so easy. Of course, perforators must be always saved. Basilar tip. So if you hurt one perforator, the patient is invalid.
Thank you.
Is invalid, bedridden.